Great. Good morning, everyone. Welcome to Skin Healthcare's first webinar of 2017, the importance of skin integrity under the Impact Act. My name is Brooke, and I'll be your moderator for today. All attendees will be in listen-only mode, so if you have any questions, please type them in the question and answer box on the right side of your screen. Before we start, I'd like to go over a few features of this webcast. You'll see several icons on the bottom of your screen. Here you'll be able to find more resources on Oasis and the Impact Act. You'll also find the slides to this presentation and links to Shield Healthcare's LinkedIn, Facebook, and Twitter pages, where we post articles for healthcare professionals and patients on a daily basis. Our speaker today is Judy Adams. Judy is the president and CEO at Adams Home Care Consulting, where she provides education and consulting services to home health agencies, hospice associations, and health systems. Her topics include best practices for ICD-10, operations, education, and compliance. Judy has a lot of great content to share with us today. Her presentation may run up to 90 minutes. If you can't stay for the entire presentation, we are recording this webinar and we'll be releasing this recording within the next 48 hours. Please visit shieldhealthcare.com/community to find a link to the recording. Okay, so let's get started as Judy has a lot of great information for us today. Judy, it is all yours.
Good morning, everyone, and welcome. I'm glad that you could join us today, and you might wonder about today's title, but the actual connection between the importance of skin integrity and the Impact Act is this is the beginning, the first year of the actual implementation of the Impact Act, and their big focus in this first year is pressure ulcers and the prevention of pressure ulcers as you go along. So that's really where it connects in. I think you'll see that as we look at some of the issues about the Impact Act. So I want to start off with our first slide, or actually our second slide, a little bit on the overview of the the Impact Act. And so we're just going to kind of go over some of that quickly, and then we're going to move on to some of the others. The Impact Act, which of course stands for the Improving Medicare Post-Acute Care Transformation Act of 2014, was a bipartisan bill introduced in March of 2014 and then was passed by the House and the Senate on September the 18th and signed into law by President Obama on October the 6th, 2014. This project is actually a multi-year project, and for full implementation, it will not be fully implemented until 2019. So you're going to see some differences. What the Impact Act does is it requires a standardized patient assessment data among the post-acute care providers.
Hi, Judy, it's Sarah.
Hi. It went off, didn't it? Are you back on? Am I back on? Okay. All right. Let me do something. The speakers sound like that. Okay. How are we doing now? Hopefully that's a lot better in terms of the sound. So we're going okay. So here we go. So looking at the Impact Act on slide number 3, the post-acute care providers are, of course, skilled nursing facilities, inpatient rehab facilities, and also long-term care hospitals and home health agencies. Because each of these groups comes in at a little bit different time in terms of implementing both their standardized procedure and or their assessment tools and also the outcomes, that's why it's going to actually take up to 3 years. So it'll be 2019 before we get completely finished with implementing the Impact Act. The big issue on the Impact Act is looking at comparability of assessment data, comparability of quality outcomes, improved care coordination and communication, and a basis for determining appropriate payment. That's the real focus and the main issues behind the Impact Act. So why do post-acute care providers matter? Well, basically, as the data in the development of the program stated, there are 32,617 post-acute provider facilities. 420 are long-term care hospitals, 1,166 are inpatient rehab facilities, 12,311 are home health agencies, and 15,000 are nursing homes. You can see that the biggest group is home health agencies and skilled nursing facilities, and that comes across when you look at some of the other data. Originally, hospices were going to be considered, and there were 3,720 hospices that were going to be considered in post-acute care, but it was decided that since hospice is basically focused on palliative care, where the other areas are more on rehabilitative care, it would be difficult to get that kind of comparison, so we didn't see that. So if you looked at it in terms of how it breaks down, about $6.8 million, or about 6.8 million Medicare beneficiaries are involved with post-acute care, $74 million in Medicare spending, and 14.8% of the total Medicare spending across all of spending goes to post-acute care. So it is a significant area. So if we look at this whole requirements for standardized data, the Impact Act added a new section within the Social Security Act to be able to capture standardized assessment. It also looks at, if you look at the post-acute care PAC providers, the need to report that standardized assessment data so that you can measure quality measures, and data on resources and other measures, because it's not just the patient outcomes, but also the financial outcome or impact of care. So the data has to be standardized. It has to be interoperable to allow for the exchange of the data using common standard definitions as we go along. Facilitation of care coordination is imperative within the Impact Act and improvement of Medicare beneficiary outcomes. The Impact Act does basically go towards Medicare beneficiaries and not all home health or all post-acute care users of all types. So we do have that issue. So the assessments had to be modified for all these post-acute care providers in order to have the submission of standardized data and also compare data across all applicable providers. So we have those kind of standards that went behind this whole program. And as we look as we go at what we have in terms of this issue, we have standardized patient assessment. Sorry, I got ahead of my clicks on that one. So on standardized patient assessment, which is on slide 6, you see the requirements for reporting assessment data. All providers that are in this system will submit standardized assessment data through the post-acute care assessment instruments. Under the applicable reporting provisions, the data has to be submitted with respect to admission and discharge for each patient. If we don't have both an admission and discharge, then we're not going to be able to have comparative outcomes as we go along with that. I'm going to see if that would help a little bit. I think that might help on the shadow. Data categories that are implemented between 2016 and 2019. 3 of the 4 types of providers actually started in October of 2016 to collect data. Home health did not start until January 1st, 2017 with the implementation of our Oasis C2. So they are tied in considerably. The kinds of categories for data are going to be functional status, self-care and mobility, cognitive function and mental status like expression and understanding of ideas, and mental status like depression and dementia. Also, we see special services as the third big category, treatments and interventions that looking at things like need for ventilators and dialysis, chemotherapy and total parenteral nutrition. And the fourth area is medical conditions and comorbidities, particular focus on some of those long-term conditions that are common for the elderly and for people who come to post-acute care, like diabetes, heart failure, and pressure ulcers in particular. Big focus on those pressure ulcers for that first year of implementation, which is this year, 2017. There are other impairments that are being focused on, like incontinence and impairment in the sites hearing, seeing, and swallowing, because those do impact the needs for patients and how they're providing services. And then other categories as required by the secretary. So it's got areas for further improvements or expansions that would be there. So why do we have to even have this whole issue of standardized data? Well, if we're looking at the standardized data, the reason for it is 1 in 5 fee-for-service Medicare beneficiaries is admitted from an acute care hospital. They're admitted to an acute care hospital each year. And of those patients that are in acute care facility, about 42% actually go to one of the post-acute care settings following their hospitalization. About 23% to home health, 17% for skilled nursing, which are the ones that are really tracked because they're the most common. Inpatient rehab hospitals and long-term care hospitals kind of share the rest of the overall, about 2 or 3% of patients that go to a PAC setting. But patients also can go to more than one setting following their hospitalization. For instance, it should be 7.8%, not 78%. So 7.8% of patients transfer from acute care to skilled nursing facility and then to home health. That's probably the most common of the transfers that may have, but we can see that the biggest volume, therefore, is on skilled nursing and on home health and what's going on. So in looking at our data element standardization, the 3 main goals are to achieve standardization or align and harmonize the data that comes in from each of the settings. This improves care and communication for individuals across the continuum, which will be really, really important on transitions. The standardization of data enables shared understanding and use of clinical information, and that issue basically enables the reuse of data elements for transitions to care, for care planning, for referrals, for decision making, for quality measures, for payment reforms, etc. It also supports the exchange of patient assessment data across providers, so you have that good history and solid information at each level. And it influences and supports CMS and industry efforts to advance interoperability and that exchange of health information and care coordination across settings, a really important goal as we're going forward in healthcare. The third big issue related to data element standardization is that unique data elements specific to the PAC settings will also persist. While the first 2 issues here relate to the impact and the sharing of information and the clarification, the last issue just stresses the fact that each of the post-acute care types of facilities will still have their own quality improvement activities. They'll still be looking at opportunities to improve their own settings and their own outcomes. So that's why there will still be some of those unique pieces. If we look at the issue of interoperability as defined on slide 9, the data follows the person. The Impact Act requires CMS to make post-acute care assessment data elements interoperable to allow for this exchange of data amongst all the different post-acute providers, other providers, individuals, their families, physicians in particular. All too often, a patient's physician does not even know the patient was in the hospital, never mind that they've gone on to another post-acute care area. So it's important to get some of that information clarified. CMS is going to make public reports of the PAC assessments, data elements, and map it to IT standards, much as we see now with home health compare, skilled nursing facility compare, inpatient rehab has a compare. Everybody has a section on the lines of having comparative data that's publicly reported. So we're going to see some of that. The use of the standardized and interoperable PAC assessment data, those elements are key enablers to achieve service delivery, payment reform that CMS wants to see in its quality strategy. In fact, that's the biggest issue for the driver for CMS, is to look at both payment reform and quality. This slide actually, on slide number 10, is a quick illustration how that assessment data that each of us collects in our particular assessment area, in our particular setting, care setting, can lead to giving information on care planning and decision support, on quality improvement, on payment, on quality reporting, and on care transition. And the better we are at accuracy in collecting data, and the better we are at being able to transfer it into this area, the more helpful it'll be to healthcare overall. So that's one of the key issues that here. And all of us use that data now for our individual settings, but look how much better it will be when we can compare between settings to look at, are there certain advantages from one setting over another for patients with particular diagnoses or particular situations. So the ideal the ideal state that we could have in this whole issue is that facilities are able to transmit electronic and interoperable documents and data elements, the convergence in language and terminology. This is so important so that we're all talking about the same thing in the same way. So we have those kinds of issues that we're going to be looking at. We also have the third one that's really specific in terms of their basis on impact from patient data is data elements are clinically relevant. So making sure that we're really measuring what's important to know about a particular patient. So these first three measures are really patient-specific data. The last measures are looking at some systematic kinds of issues. So care being coordinated using meaningful information that is spoken and understood by all. Having just a common set of language is so important to be able to clarify information and to make sure that we're all talking on the same way. Measures can evaluate quality across the settings and evaluate intermittent and long-term outcomes so that we can do some comparative work and also see how they work together. The measures in the information follow the person. So I don't know about any of you, but it's always difficult after a while to remember all of that history. People keep asking the same questions over time, but trying to remember all the things that happened in history, how much easier if we could just share that information between settings and be able to get that information. And then incorporates needs beyond the healthcare system. So we're looking at support systems, we're looking at other kinds of needs that patients might have that would impact how they do with care and what goes on. So basically, the Impact Act is part of the CMS Quality Strategy, and the CMS Quality Strategy is based on a national quality strategy called the Triple Aim: better care, healthier people, smarter spending. The goals of this are making care safer, strengthening person and family-centered care, promoting effective communications and care coordination, promoting effective prevention and treatment, promoting best practices for healthy living, and making care affordable. That is a big mouthful of goals and some very significant kind of issues. But what it really does is we really cannot determine the true value of the post-acute care services without having consistent measures. And that communication across caregivers in acute care, post-acute care, social support settings. Some of the key things are similar patients being discharged from different types of post-acute care settings? And if they are, do the outcomes, are they similar for different settings? Or are there certain settings that seem to support better outcomes? Or maybe a combination of different post-acute settings that can benefit the patient the greatest? So there's some really key questions to answer, and we won't have all those answers right away. It'll be coming about as we work through this system. So if we say what outcomes are expected from the Impact Act, standard terminology to measure patient complexity, that is actually one of the biggest issues that we have that we really need to have. Another thing that we have is changes between at any point. That communication should be any point in time during the stay or across services. Changes between admission and discharge from home health. That's where our outcomes come from. That's where we can see whether we made a difference or not. Communication across caregivers, and that's physicians, that's each of our different types of facilities, and other kinds of individual caregivers that might be working with a patient. determining resource needs to what we need to be able to take care of that patient, and also setting payments equitably and improving the value of care. So all of these kinds of things are expected to be enhanced as a result of the Impact Act. And that's why it is such an important piece of legislation, and it will be important as we look at how we're getting it and getting the information from it. Impact will improve care coordination without a doubt. It can facilitate that consistent and reliable definition of the patient's complexity and needs, definitely improve communication across an episode of care. If we're using common language across medical professions to define patient complexity, we're already way ahead of where we are. We know that each one of us in our own specific healthcare setting and even our own individual disciplines has a language of our own. Sometimes it's difficult to figure out which all those languages are, but looking at more standardization, we can share data and information much better. The allowing interoperability of data across organizations involved in an episode of care, helping us to coordinate those things so we're working together and not going in different directions at the same time, and certainly preventing potential adverse events. We don't want to have any of those adverse events. Some are potentially avoidable. Some of them are not going to be avoidable, but anything we can do to improve the outcomes would be better. The improved communication with the post-acute care liaisons about complexity from the transfer. So we start on a knowledgeable base instead of all of us starting from ground zero at the same time. Why do we have to reinvent the wheel and always do those kinds of information? So that's a good part of the issue, and we will see that Impact will improve that care coordination by enabling timely transfer of information about the patient's medical status, their functional status, cognitive status, and care preferences. That timely transfer of information to patients' other caregivers, primary care physicians, family members, residential support systems, and all of us that are participating in this type of program means that the care is a better quality and the patient gets better benefits. Who could argue with that? That's certainly a good thing to have when we want to have it. This slide on number 16 is taken from some of the presentations that CMS has done about impact. And what it's really doing is taking the 6 major areas of goals: the patient, community health, care coordination, clinical quality of care, person and caregiver centered experience and outcomes, safety, and efficiency and cost reduction. And it's defining those, and you see that function is in the middle. That's all impacted by each of these areas, and then each of those big areas have subterms underneath it. So the whole goal is that the measures need to be patient-specific, patient-centered outcomes, and whenever possible, they should be outcome-oriented. Measures, concepts in each of these 6 common domains, they're common across all providers. We're all looking at these areas. So why not share some of that information and improve it as we go along? So we see that issue. There's considerable work that is required to reach comparability in that core set of measures for all of these 6. And that's why it's taking more than 3 years to fully implement the issue of the Impact Act. So again, the Impact Act quality measures, they require CMS to develop, implement quality measures using cross-setting standardized patient assessments, which means looking at all the assessments and seeing where there's commonality, where it needs to be changed and introducing those changes, and also looking at that information across all 4: long-term care hospitals, skilled nursing facilities, inpatient rehab facilities, and of course, our home health agencies. So we're looking at skin integrity, functional status and cognitive function, medication reconciliation, incidence of major falls, and medical conditions and comorbidities. Not all of them are starting this year. Really, only a portion of them are starting in 2017. And you have probably seen the notices saying there are some new measures that are being looked at and asking for your impact or your input in determining whether these are good measures and whether they will be effective or not. So in looking at our measures, our impact measures, In addition to clinical quality measures, the Act requires CMS to develop, calculate, and enable measures that will look at resource use, including Medicare spending per beneficiary. That's actually starting this year. Hospitalization and readmissions. We all know that's one of the highest costs to the healthcare program and particularly to the Medicare program. And that's also going to be looking at this year, as well as discharge to the community. What our ultimate goal is to make sure patients stay in the community, that they're able to manage independently, and they're in an improved situation than they were when they went into acute care or when they went into our post-acute settings. So as we look at this is the home health outcome data expected to be collected in 2017. You see that we have basically down the left-hand column, we have 5 areas that are focused for 2017. In skin integrity, the big focus is the percent of patients with new or worsened pressure ulcers. And that Oasis data collection is definitely set for 2017 and required changes in our Oasis assessment tool. Medication reconciliation, the drug regimen review and follow-up for identified issues really has a great impact on rehospitalization and on increased costs to the program. So that data is also being collected. That one doesn't tie in as much to our skin integrity, but it does tie into overall needs for patients. And then the 3 resource uses areas are the total Medicare spending, estimated spending per beneficiary, looking at from start of care of an episode wherever you might be in whatever setting to 30 days after the end of the treatment period. So it's looking at not only what happened, what were the other expenses while we're providing care, but also the issues of beyond that time. And discharge to the community means we want to have no unplanned rehospitalizations and no deaths within 31 days post-discharge. So you'll see as we look at some of these, that's why the risk adjustment is so important, and we only consider those patients for which we really can make an impact on this situation. Potentially preventable 30-day post-discharge admissions is looking at a situation of not only during the time we're seeing the patient, but also the 30 days following it. And you can see that the time period for data collection varies. So discharge to community, that data is actually collected to be reported over 2-year time periods at a time. And resource use for the potential preventable hospitalizations or readmissions is actually looking at a 3-year time period. The data we've already been submitting is already being collected. So on the hospitalization, it started in 2015, the data from 2016, and in 2017 will be the third of the 3-year collection to report it in 2018. So rather complex situation when you look at all of this. The risk for risk adjustment and the details for that are really important, making sure that we get accuracy on our assessment tool and that we're looking at these outcomes both individually in our agencies, in our settings, and across the settings. So we have all of those issues. So you see in some of those, actually, let me go back to that slide for a second, just to highlight a couple of things. So if we're looking at total Medicare expenditures, that's everything that's paid for under Medicare Part A and Part B during the time a patient is receiving post-acute care services and for that 30 days after the end of care. It could be physician services, it could be supplies, equipment, other settings that they're going to. There's many things that would be included in that. If we look at the issue on discharge to the community, we already mentioned that we want to make sure we don't include patients that died within or we're trying to avoid patients dying within the 31 days after discharge and that had unplanned hospitalization. That means if we discharge a patient and we know they have a planned readmission, maybe they've had something done but they have to have further follow-up on surgery, or if they're discharged to hospice, whether it's a facility or a home-based hospice, then the likelihood of death within 31 days is higher, including those people that are at higher risk for hospitalization because they're already planning a readmit, or patients who die within 31 days would skew this data. And so they are excluded. And it's important to understand the risk adjustment and who is included and who is excluded from these measures. So there are details on the CMS website related to the Impact Act that give you the details about how each of these outcomes is classified. Well, I mentioned that some of these things are going to come in over time. So our future home health data for quality measures, not counted this year, most of this is actually going to start being collected. It's collected during these time intervals. And in fact, there are a number of measures being evaluated now as to whether they're appropriate or not. But officially, the Oasis data collection will begin in 2019 for home health, for functional status, which is going to be mobility and the impairments in hearing, seeing, swallowing, and incontinence, cognitive function, looking at the ability to express and understand ideas, depression and dementia, the incidence of major falls. That'll be a significant one, and a real difference in terms of whether you're talking about a patient in the home health setting, which is intermittent care, versus a patient who's in an inpatient facility like inpatient rehab, where there's staff around the clock, and there's more supervision that can be available on an ongoing basis. So we have all of those differences that are there and have to be measured out, and finding the measures that work across these settings. And then communicating and transferring information and care preferences, so important for making sure that patients continue to have the care that they need and benefit their outcomes that we have. We need all of those pieces. So that's what the future ones. Now, nursing homes and long-term care long-term care hospitals and inpatient rehab facilities, they may start in the measures earlier, probably in 2018, but home health has always been the last part to come on board for this piece. That's just the way they set up that calendar. So let's look at home health and, of course, the impact items integrated into the Oasis for 2017 focus primarily on skin integrity. But let's look at what happened to Oasis C2 this year and how Oasis is probably the most, well, Oasis has always been probably the most important tool used in home health because it's used for so many issues: payment determination, outcomes, survey results, all kinds of things. So looking at what we're doing, it's even more important now that we go to impact. So why about the importance of skin integrity? Well, identifying new and worsening pressure ulcers is one of the major outcomes in the first phase of implementing the Impact Act in 2017, and it's all related to skin integrity. The development of pressure ulcers and certainly the worsening of pressure ulcers has a major financial impact and certainly great impact on the quality of patients' lives. So most of the changes in Oasis C2 for 2017 tie into this changes either risk adjustment related to the development of pressure ulcers or worsening of them, or actually measuring them. It also resulted in a number of definition changes from what we've been seeing for a long period of time. Home health personnel need to pay particular attention to identifying the risk factors for pressure ulcers, ensure they're monitoring any closed, which means reepithelialized, stage 3 and 4 pressure ulcers for possible breakdown, and actively instructing patients and caregivers in pressure ulcer prevention strategies. These are best practices, but they're vitally important if we're going to have a good impact on both the outcomes and the cost of care for folks. So what are some of the skin integrity contributing issues? Well, this list is certainly not all-inclusive, but hits some of the high points of why our post-acute care population is at risk for skin integrity issues. The high percentage of elderly patients that are seen in all the post-acute care settings. The decline in function, especially mobility and activity limitations, which means the person's not as active, they're not in as good a shape as they were before, they're more likely to develop skin breakdown. The presence of bowel and bladder incontinence with the irritation on the skin, the problems you can have from that from skin breakdown. Patients living alone may not have the ability to do their own self-care or may not have reliable caregivers that can come in and help them out. Caregivers may be unwilling to learn or to follow pressure prevention activities. And so we end up with pressure ulcers that should have been preventable, but again, in our setting in home health in particular, we're not there all the time. So we do our best to try to convince our caregivers about how to follow through, educate them, make sure that they know the information. Lower extremity wounds and ulcerations are so common, both in all of the post-acute care settings and as our population ages. Whether it's diabetic ulcers, peripheral vascular disease, either venous or arterial, skin tears, open wounds, weeping edema with blisters, abscesses, cellulitis, and so much more. All of these issues are patients that are seen in post-acute care as well as acute care. And then what happens? It certainly does take away from their ability to be resistant to some of the skin breakdown issues. The presence of limitations related to vision, sensation, cognition, depression, dementia. So patients may not understand or may not be able to follow through in terms of what to noticing and being able to report or follow up with the physicians on things that have changed. And then multiple comorbid conditions that increase the complexity of care. Nobody today definitely does not understand the issue that our patients have gotten complex. Well, maybe MedPAC and some of the CMS people who follow, they seem to always think that we are saying patients are more acute than they are, but I think those of us that live in the real world know that we really do see a lot of complex patients in post-acute care, especially in home health. So let's look at those 2017 changes to Oasis specifically. The first one was M1028. M1028 is active diagnosis of peripheral vascular disease, peripheral arterial disease, and diabetes, or diabetes. There are only 2 lines in this one, and it's saying that on admission, because this is checked out, on admission and on resumption of care, does the patient have one of these diagnoses? Peripheral vascular disease or peripheral arterial disease is at response 1. Diabetes is at response 2. What they're looking is 2 specific diagnosis categories, whether they're present and whether they're active conditions for a patient. The diseases and conditions in this item require the physician to clearly state or indicate how this patient has active treatment for these areas. These diagnosis categories definitely influence a patient's functional outcomes and increase a patient's risk for development or worsening of pressure ulcers. So they're key in that particular area. You can check both if the patient has 2 separate diagnoses for one of the peripheral diseases and diabetes. But if they have a combination like diabetic peripheral vascular disease, then we would only code or check the diabetes because there is no requirement to add an additional code for the peripheral vascular disease in addition to the diabetes. So there are some differences in there, and it's important for us to know what goes on and how we would score those. The other thing is that you don't get any more credit for checking 2 of those, 1 and 2, than you do for either one of them. But it is important, because those comorbidities are important, that we include the information in the medical record. If a patient does not have an active diagnosis of one of these conditions, then the boxes are left unchecked. Now, in the guidance manual, there are a specific list of all the codes for the conditions that are acceptable to list for the peripheral vascular disease and the peripheral arterial disease. There are also a listing of all the 6 categories of diabetes. And really one of the categories is just unspecified, which is a default to stage 2. Because all of those diagnoses, just a lot of the diabetic diagnoses are combination diagnoses and may have other things going on in addition to the diabetes, which is considered related to the diabetes. You can use a dash in this item, but a dash means that there's no information available and I'm not able to do any kind of assessment. What does that do to this item? It takes it out of being able to be used as a risk adjuster and it doesn't give any of the basic information. Home health may struggle with this a little bit more than some of the other settings. I don't think so much in M1028, but I think you'll see in some of the others we may have more trouble doing some of this than perhaps some of the other settings that have available to them more resources because they are in a confined facility. So information including past medical and surgical history needs to be obtained from family members, close contacts, the patient. This is, for home health, this is our clinicians, their responsibility when they're doing the assessment to get the data, collect as much data as possible, and then, where necessary, confirm or verify the data with the physician to make sure we are capturing those situations that are potential risk for developing the pressure ulcers. And although the open communication regarding diagnostic information between the physician and the clinician is important, it's also essential that any diagnosis communicated verbally are documented in the medical record. So if our staff calls the physician to say, I went out to see Mrs. Jones and it appears that she has these kinds of symptoms, could you tell me what her diagnosis is, or could you confirm she's telling me that she has diabetes and has had for a long time, or that she's been told before that she has peripheral vascular disease? Do you concur with that or not? So if we do any of that verbal clarification, we need to make sure that we document it. So the active diagnosis is basically something that has a direct relationship between the diagnosis and the patient's current functional, cognitive, mood, or behavioral status, medical treatments, or the need for nurse monitoring, or the risk for death at the time of the assessment. Nurse monitoring can relate to anything, a condition, a particular vital sign, or a symptom that we're monitoring, but it's a regular evaluation and monitoring of what's going on. We cannot infer a diagnosis based upon association with other conditions, but remember that our guidelines and coding have some significant changes for 2017, and anything with the with provision, which is a convention, and it's listed in the alphabetic index under a main condition like diabetes, and then the word with is indented under it, and underneath the word with indented are a whole bunch of other conditions. There's an automatic presumption that these things are related. But there's a key to that. And the other key is unless the physician specifies there is another cause or that they are not related to one another. So it's changing the way we code, it's changing the way we see patients, and it's changing what's happening on our Oasis. Let's look at a couple of case examples to see what we're talking about. In this case example, number one, it's a patient who has insulin prescribed for diabetes, requires regular blood glucose monitoring to determine whether the blood glucose goals are achieved and by their current medication regimen. And the physician progress note documents the patient has diabetes mellitus. This clearly leads itself to an active diagnosis of diabetes, and response 2 would be checked. If this was a patient who had, say, diabetic peripheral vascular disease, if it said diabetic peripheral vascular disease, or it was connected in any way, it was not said that they are separately or not related in the clinical record, particularly if it said they were not, if they were unrelated. Unless that happens, we would just click on the diabetes, and we would not also say number 1 response for the peripheral vascular disease, because E11.51 is type 2 diabetes with peripheral vascular disease, and there's not another code required. And then our other categories of diabetes would use the same E08, E09, E10, and E13, but the 0.51 would be the same, saying it's diabetes with peripheral vascular disease. So they're connected. So another example, this is Mrs. B, who is admitted to home health for physical therapy after a hip replacement. And the patient also has type 2 diabetes controlled by diet. She independently takes care of herself, monitors her insulin, checks her feet, checks her general foot care, is doing good. She does all of the things she should be. But the therapist recognizes that because a change in the activity provided by the therapy could affect her blood sugar levels, and because diabetes could affect her ability to heal from surgery, that the diabetes meets the selection criteria for a secondary diagnosis and would be reported as a secondary diagnosis in home health, other post-acute settings as well, and that the physical therapist will be monitoring that patient holistically, not doing anything directly with the physical therapist, but with the diabetes, but asking the patient how their diabetes is doing. Are they having changes in blood sugar? Are they seeing any different changes? So clearly the diabetes is related to this particular patient and is an active condition. So the second example also has diabetes as an active condition. If we look at example number 3 on slide number 30, what we're seeing here is a patient who had a below-the-knee amputation due to gangrene that was associated with peripheral vascular disease. And of course, we all know peripheral vascular disease does not go away just because you have a portion of a limb amputated. If there's still any of the limbs left, then you still have peripheral vascular disease. Patient does require dressing changes to the stump, monitoring of the wound healing, and peripheral pulse monitoring for the other leg, and also looking at the peripheral pulse as far down as we can, at least up in the groin area above this amputation. The physician progress note also documented the patient has peripheral vascular disease and a left below the knee amputation. So in this case, we can check off response 1, peripheral vascular disease. As far as we know in this case example, the patient does not have any diabetes. But with everything documented by the physician note and the orders that are there, this patient is receiving active treatment. So we have a lot of that as well. So all in all, we've got a number of examples where this is a key item to look at what's happening with home health and with that particular patient. So let me go back one. It was just a little slow coming in, sorry. So that's an issue of a new item that came up mainly because of its impact on the risk adjustment for pressure ulcers. In M1311, and what we're going to see in a minute in M1313, these are questions that have been revised under Oasis C2 and include a number of different definitions than those that we have used for many, many years in home health. Actually, home health is the only one that used some of these definitions. So it's a big change for us, and the other post-acute care providers don't see it as a big change because they didn't have the same thing that we had. So M1311 is looking at the number of current pressure ulcers at each time of assessment, and it has new and revised terminology and guidance that differs from what we did in Oasis C1. The biggest one is the terminology that specifies that healed versus unhealed ulcers is different than closed versus open ulcers. In the Oasis C1, if we had a stage 3 or 4 pressure ulcer, it was always considered unhealed as long as it always was. Even if it has closed over and epithelialized, it was still considered an unhealed pressure ulcer because the underlying tissue wasn't healed. No one else was doing it that way. So for Oasis C2, that definition has been changed, and stage 3 and 4 pressure ulcers that are now covered fully with new epithelial tissue, so it's closed all around the edges of the wound, are no longer considered unhealed pressure ulcers for Oasis. But they are vulnerable. They continue to be vulnerable for skin integrity. They still have about 80%, only about 80% of the tensile strength of fully normal tissue. And so we still have a responsibility for monitoring those areas and making sure we're not getting breakdown in those areas. And if we do get some breakdown starting, that we're going in and working on it very quickly. So looking at this, there are 2 lines in this question. Line 1 is completed at all time points, and it's clearly asking what is the number of the current pressure ulcers at each stage Now we only look at stage 2 and higher for this, so stage 2, stage 3, and stage 4, but it also looks at the number of pressure ulcers that are unstageable, either due to a non-removable dressing, due to the wound being covered with eschar or slough, so you can't see the stage, you can't determine the stage, or unstageable because it is due to a deep tissue injury. We took away the word susceptible or suspected from the definition this year, but still, if we think it is a deep tissue injury, then we would not count it. Line 2 is only used at follow-up and discharge. So if I'm doing a resumption of care or a start of care, I don't have to fill out line 2, but I do have to fill it out at any follow-up or discharge. And again, we're looking at the same definitions: stage 2, stage 3, and stage 4 ulcers, and those 3 types of unstageable ulcers. So as we look at M1311, we have some guidance, and the guidance is important. It's telling us that we do not report in this item stage 1 pressure ulcers because they're not considered reportable under Oasis. Pressure ulcers that have healed, that are totally closed and healed, have re-epithelialized. Now they're closed and they don't well, they do re-epithelialize in both stage 2s as well as 3s and 4s. So if they've closed up and there's nothing open on that wound anymore, then they are healed. When we have some of our unstageables, they will not be considered healed. So a stage 1 pressure ulcer, although it doesn't have any open skin, it's got intact skin, it's not considered healed, but it's not counted in M1311. It'll come up again later on in M1322. Stage 2 pressure ulcers, as long as they exist, are considered unhealed. Now, once they cover over and the tissue is intact across the surface, the stage 2 pressure ulcer is gone, and we don't count it anymore. It's not considered unhealed. So we have suspected deep tissue injury, and those have intact skin, but they are a very major ulcer because the problem is going to be if they open up again, or if they open, they may be a very nasty wound. The unstageable pressure ulcers, whether they're covered with a non-removable dressing or eschar and slough, there is a wound there, and we need to see about what's going on with that. So that's not healed. There's something going on there. I may not be able to stage it, but it's definitely an open wound. So we have some further guidance at 1311. It says that we should follow the WOCN, Wound Ostomy Incontinence Nurses guidelines and definitions, and the Oasis Guidance Manual. The Oasis Guidance Manual has some few differences of opinion between the two groups, and of course the Guidance Manual takes precedence, so we would have to follow that. Now we also found some other issues that came in the clarification here. One is that we have, if we surgically debride a pressure ulcer, it's still a pressure ulcer. It's not a surgical wound. That didn't change. That's the same as it's been for years. Pressure ulcers that are suture closed are still considered pressure ulcers. They're not considered surgical wounds because no surgery was done, just closing them up, just stitching them closed. We want to make every effort to document and to contact previous providers to find out what level a particular pressure ulcer was at any given time, because we never reverse stage a pressure ulcer, so that's real key as we look at this issues. But now here comes the changes. So if we look on slide 35, we see that on slide 35, it's telling us that any kind of skin graft, whether it's a muscle flap, a skin advancement flap, a rotational flap graft, or just a skin graft just across the surface, any of those are considered now surgical wounds and not pressure ulcers. That's a significant change, particularly with the skin grafts, from what we have had for many years now, which still allowed them to be coded in Oasis as a pressure ulcer, but now they are not. They are considered a surgical wound, and you can no longer count them as a pressure ulcer. So all of these kinds of grafts, that's a change for us that we have. We also have this other issue called present on admission, a term that we're not familiar with in home health. That's usually been a hospital term. But in terms of looking at pressure ulcers and comparing them across stages, it's very important to determine, was the pressure ulcer there at the start of care or resumption of care, which are the admission times or considered the admission times for home health. So, or did it form during our home health episode of care? In case of the other post-acute providers, it would be their episode of care. So if a pressure ulcer was unstageable at start of care or resumption of care, if it becomes numerically stageable, say 2 weeks later, then that determines what its stage was at the start of care. You don't go back and change it necessarily, but it has an impact when you are answering other questions, and we'll see that. So the first time it becomes numerically stageable is, and we knew it was there, but we didn't know what the stage was on admission or on a start of care or resumption of care. That first time it's stageable is counted as its stage on admission. If the ulcer subsequently increases in numerical stage, you don't change it in terms of saying what was there at start of care or resumption. Now at discharge assessment, it will be showing it what it is at the discharge time, but not changing to what it was at the admission. So the general standard of practice for patients starting or resuming care is the patient assessment is completed beginning as close to the actual time of the start of care or resumption of care as possible. Even though we have 5 days for start of care and 48 hours or 2 days for a resumption of care, the first time we see the patient is when we have to evaluate what that pressure ulcer is and what its stage is. And so we cannot show a worsening of an ulcer. For instance, if we see it on day 1 and then 3 days later we see it, on day 1 it was a stage 2 and 3 days later it's deteriorated to a stage 3. We cannot say that it was a stage 3 at start of care, resumption of care, because we saw it earlier and it was a 2. So it's a little different if it was not unstageable. So let's look at some examples as we look at these. In this example, a patient was admitted with a stage 3 pressure ulcer on her right hip at the start of care. She had no other pressure ulcer. At follow-up, which would be probably a recert or for some other reason we did another Oasis, the patient's ulcer was assessed as unstageable due to eschar and slough. The patient was then discharged 3 weeks later because her daughter came from out of town and decided to move the patient back with her, and she lives in another state, so we're discharging the patient. By discharge time, we do that third assessment. The ulcer on that right hip is assessed as a stage 3. There is a new stage 2 on her left ulcer. So how do we answer M1311 at each of those time points? It takes a little practice to look at these, but what we see in this situation is at start of care, she had a stage 3. It was clearly identified at a stage 3 at that time, and so we would use that. When she had her follow-up, that follow-up assessment, when it was done, according to the assessment notes, it said that now it was unstageable, so I can't give it a stage. We know it was a 3 before, but I can't say it's a 3 now because it only showed as unstageable. You notice that at start of care, I only filled up line 1 because I don't do the second line on start of care or resumption of care. At follow-up, I have to do the second line as well as the first line. So I know that there's an unstageable now, but was there an unstageable when she started? No, because the second line says, was this same ulcer at the same stage there at the start of care, or the most recent start of care or resumption of care? At the start of care, it wasn't there, not as an unstageable. So the answer is 0. You can see you could fall into a trap fairly easily saying, but she had a 3, a stage 3, and we can't make that go away. So I know she had an ulcer there, and I know it was a stage 3 before. No, you don't want to do that because we are not taking credit for that at this point. At start of care, she did not have an unstageable. So that's how we would answer this question. We got to discharge, which was only 3 weeks after the follow-up, but at that point, She has a new stage 2 pressure ulcer on her left hip. So I'm going to list that as one. And she has that pressure ulcer that was on her left hip, which was a stage 3. It started care, then was unstageable. It's now been cleaned up. I can see it's a stage 3, so I can list it as a stage 3 now. So then I go down to line 2 because it's discharge, and I say, okay, was there a stage 2 on her right hip before? No, there was not at admission. So the answer is 0. And in the B for the stage 3, at start of care, did she have a stage 3? Yes, she did. In the middle, it went to unstageable, but at this point, it's a stage 3 because it is the same and it was there before. Same place, same level. And that's the difference between that follow-up and the discharge. So if I look at this, how many pressure ulcers worsened for this patient? Actually, only one. That one on the left hip that went from no pressure ulcer to a stage 2. The other ulcer on the left hip, she was admitted with it as a stage 3, got a little bit messier when it was unstageable, and now it is a stage 3 again. So it didn't improve. It did not necessarily improve, but it also did not worsen. So the only worsened one was actually that stage 2. So that's kind of an example of what happened with that one. So that leads us to moving on to our friend at our new area of M1313. M1313 is completed at discharge, and at discharge it's wanting to know the number of pressure ulcers that have worsened since the start of care, resumption of care. Seems like we just looked at that in M1311, but we're looking at it in a little bit different way. So now we're going to look at it for this particular question, and we're basically going to go down and we're going to ask ourselves, this is what the question looks like. And it's saying what is the number of current pressure ulcers that were not present or were at a lesser stage at the most recent start of care. And then we're going to be looking at what's changed from that. So as we look at this one, we really need to do it in 2 steps. So if we look in 2 steps, the intent of this question is to look for pressure ulcers that were present at discharge that are new or have worsened. And worsened is defined as increased in numerical stage. Just the fact that the ulcer got infected or it had a lot of slough or eschar does not make it worsen from this question. It's only if it changes the numeric number. 2 to a 3, 3 to a 4, 2 to a 4, whatever it might have been, since the most recent start of care or resumption of care assessment. I'm going to have to look back to whenever that was. In home health, looking back to the most recent start of care, resumption of care for a patient who's on service for a period of time could mean you're looking back for some time. Particularly if the patient has not had a hospitalization with a resumption of care, you're going back to the start of care. And you may have many treatment episodes between the start of care and when you are looking at this patient at discharge. So you're going to have to go back to the beginning to figure out if there was a change. So in looking at this patient, we really need a 2-step process. And the 2-step process is first to compare the current stage of each pressure ulcer at discharge to what stages that ulcer was in the past. Again, I'm looking back in the record. Was it worse before? Has it gotten worse or not? So what was it originally? What is it now? We never go backwards. We only go forward. And the second part is I have to count and report the number of pressure ulcers at each stage that are new or have progressed to a deeper level, and therefore are staged at a higher number, the stage 1 through 4, since the last or most recent start of care or resumption of care was completed. Now, this 2-step process is important because if you just count the number of pressure ulcers at each stage or the number that are unstageable, you will not get the same data. So you really have to do it in the 2 steps to know which ones got worse. Some of the ones that were there before might have gone away. Some of them did get worse, and some of them have stayed the same. If you don't do it in the 2 steps, looking first at each pressure ulcer and has it changed from the beginning, or from the most recent start of care, resumption of care, you will end up taking credit for many more worsened ones than you should. We don't want to do that. We want to show how good we are and that we don't have that happening. Now, sometimes it happens. It's not because we don't provide good care. It's because of all those other factors that patients have that contribute to the development and the worsening of pressure ulcers and the whole skin integrity issue. So again, and I've said this 2 or 3 times already, but it really bears repeating as many times as needed, we do not reverse stage pressure ulcers as a way of documenting their healing. Lots of folks want to do it because it shows they got better. I had a stage 3 when they first came on. My good care has managed to close it up. It's not actually as deep as it was. It's really now only looking like it hits the stage 2 structures. But that pressure ulcer never goes back to normal. So we could not reverse stage it, and that's really where it comes from. We can put a dash in this question too, but those dashes are kind of tricky. A dash is saying there's no information available and I cannot assess the item. Well, what that means is I lose my opportunity to do assessments. I lose my ability to get the assessment data, but also I lose the opportunity for the risk adjustment. So I don't want to use the dash if I can help it. There will be times, for whatever reason, that I cannot have enough information about that patient or I cannot do the assessment. Those should be relatively infrequent. And as a matter of fact, CMS says that the dash is usually used only at an unexpected transfer or an unexpected discharge when the patient has already transferred or discharged and you didn't know about it, or there wasn't time for you to go out and reassess the patient before they transferred. The fact of having a dash at a start of care or resumption of care would not be a good thing. Why would we not be able to look at that area and assess it? That would cause problems for us, not only on our outcomes and our assessments, but probably on survey as well. Because how could we know if that ulcer is getting better or it's getting worse or we're taking good care of it unless we see this issue? So dash, be careful about those. Pressure ulcers that are unstageable at discharge due to a dressing device, such as a cast that cannot be removed to assess the skin underneath. You cannot report those as new or worsened because they may look worse than they did before, but if I can't stage them, then I can't compare them to the previous stage that I had. And I don't want to take credit for showing those as worsening when they weren't. So they're really unstageable, and I would not indicate that they are worse. So if it went from a stage 2 and now it's unstageable, pretty good likelihood that it probably got worse, but I can't stage it now, so I can't really say that. Typically, stage 2s do not develop eschar and slough, but stranger things have been known to happen. So, some issues not to forget. Once a pressure ulcer is fully granulated and the wound surface is completely covered with new epithelial tissue, that ulcer or wound is considered healed, and it's no longer reported as an unhealed pressure ulcer. That's a huge change for home health from what we have done for years, and it is going to be an expensive one because we received a lot of case mix points in home health for those unhealed pressure ulcers that are closed over, which we will not have anymore because we cannot answer that as a unhealed pressure ulcer on the Oasis. A previous stage 3 or 4 pressure ulcer that breaks down again would be staged at the worst stage it ever achieved, and that's why that documentation is so important. What was it originally? What did it get to? What was its worst stage? Because it will never be coded less than that. And if the pressure ulcer was unstageable for any reason at the most recent start of care or resumption care, you cannot assume that it's worsened now, because unless at some point between the start of care, resumption of care, and discharge, it became stageable, if that didn't happen, then you don't know what stage it was to begin with. So how can you say it's worse at discharge? Whatever stage it is at discharge. I don't have a base to go against for that. These are really important points because you don't want to get these answers incorrect and end up with a lot more than you want to have. So hints to scoring correctly. If the pressure ulcer was unstageable at start of care, then was stageable on a routine visit, the follow-up assessment by discharge, the pressure ulcer has increased in numerical stage since the routine visit and follow-up. Well, it's had changes. You've got changes that you could see the stage, and so at discharge, if it's worse, it has worsened. And of course, you can't reverse stage from at discharge from what it was in follow-up. In the previous stageable pressure ulcer becomes unstageable, then was debrided sufficiently to restage by discharge, you have to look at the stage before and after the debridement. If the stage has increased in numerical staging, it's got a higher number, then it's worsening. If it hasn't increased, it's not worsening. And pressure ulcers that are unstageable discharge due to dressing device cannot be removed. You can't see it, so I don't know if it got worse or not. If I can't see it, I don't know if it's the same as what it was. It's worse than what it was. I can't stage it. So this is an algorithm that is in M1313. It's only one page of it. It is available in the Oasis guidance manual. It's actually on about 2 pages because of each of the areas. So this always shows stage 2 and stage 3 as an example. The key about this is it's a great tool. All clinicians in home health, in my opinion, should be armed with a copy of this that they can carry with them, because it's telling you the guidelines about when you would show that a pressure ulcer has worsened. You follow the big arrow, the one that has the outlining around it. So if I had a stage 2 pressure ulcer and at the prior start of care, resumption of care, it was not present, it was a stage 1, it was covered by a non-removable dressing, and then documented as a stage 1 at a home visit or follow-up, the answer is yes, it got worse. Anything else is going to be no. You see an arrow, but it goes to no or NA. So this is a great tool and really helpful to take out during doing the assessments at discharge to make sure we get it right. So let's look at an example of a patient. I'm going to do this one real quickly. This is a patient who has a stage 2 pressure ulcer on her left hip at start of care. How do we keep complete M1311 at start of care? And then so if we look at that one, we're going to look at the answers on the next one. After 2 weeks in home health, well, at actually the start of care, she had 1 stage 2. After 2 weeks in home health, she was transferred to acute care for 3 days due to pneumonia. When she came back for her resumption of care assessment, pressure ulcer on that left hip has deteriorated from that stage 2 to a stage 3, and she has a new stage 1 on her right hip. So at this point, we know that at her start of care at the beginning, we know that she would have had 1 stage 2, but at resumption of care, she has 1 stage 3 that is present, and we don't count anything that is a stage 1. So on that line 1, I'm going to count a stage 1, stage 3, and because this is a resumption of care, I don't have to fill out line 2. So the patient goes on, and in the same patient at discharge, that stage 3 pressure ulcer on her left hip became 80% granulated, and the stage 1 on her right hip became a stage 2. So how am I going to complete this at discharge? Both M1311, the current, and then 1313, the ones that changed at discharge. Well, the current ulcers, line 1, at discharge, she has 1 stage 2, and she has 1 stage 3. It's still a stage 3 because it's not totally epithelialized. Which of those did she have at the most recent start of care or resumption of care? She didn't have any stage 2s, so that is going to be a 0, but she did have a stage 3 on that left hip, so we count that one. And then with her on 1313, what happens? Now, if we go, that one is looking at discharge. So at discharge, we're saying which got worse. The only thing that got worse was that stage 2 pressure ulcer got worse. It was a 1 before, and now it's a 2. The 3 was a 3 before, so it hasn't changed. So there's nothing on this stage 3. It was the same at resumption of care as it is now. And then So pressure ulcers had a number of changes. They actually have a big linkage into skin integrity as well. I want to touch on this strange numbered one, GG0170C, which is a mobility issue, new item in Oasis C2, and it is looking at, it's collected at start of care and resumption of care only, not at discharge, but it's looking at a different way of measuring transfer than the functional transfer that we have at M1850. In this case, we're looking at what kind of assistance does the patient need with a mobility task, and there's a very specific way of measuring this. We're looking at mobility from moving from the patient being lying in the bed, sitting on the side of the bed, feet flat on the floor, and no back support. There's a little bit of leeway if a person's too short and their feet can't reach the floor. You look at some safety issues on there in terms of whether they need support or not. So we're looking at the degree of assistance the person needs to make this transfer. This sitting transfer is not the same sitting transfer as M1850, which is the functional transfer. And this item is a risk adjustment for the development of pressure ulcers and the impact on wound healing, because the greater the extent of assistance the patient needs for this mobility of being able to go from lying flat in bed to sitting up to getting off or to getting to the side of the bed, means they're higher risk for developing pressure ulcers. So again, the usual performance and that specific from lying on the back to sitting on the side of the bed, feet on the floor, and no support for their back. The scoring is from starts out at 0.6 for independent, goes down to 0.1 dependent. Another key, a little challenge for home health, it's the opposite type of sequencing for scoring than anything else we've ever had in Oasis. Everything else we have in Oasis goes from the higher score being dependent and the lower score being independent. This is exactly the reverse in the scoring. So that's something to watch out for. It'll be real easy to not really, if we don't pay attention to the definition of the scores each time, because it goes the other way. All right, so when we're looking at this particular issue, let's see, let me get 49 to come up here. Okay. So when we look at this issue, we're looking at those whole scores of the items. So that now we want to go up to what do we have next? And this is the one that, there it is. So when we're scoring on the start of care and resumption of care, we're going to report one of those 6-point scales to show how the patient's doing. If the patient cannot attempt or will not attempt the activity, a caregiver does not complete the activity for the patient, then you have to report the reason the activity was not attempted, and there are 3 special codes for that, 07, 09, and 88. The patient could refuse, it's not applicable because the patient didn't perform the activity before this illness or exacerbation of this illness, or it was not attempted due to medical or safety concern, because we certainly don't want to put a person at risk of safety concerns just by insisting that they have a particular test done. So the other part of this issue, so if we looked at that one, when we're scoring, it's at start of care, resumption of care. We have the scores for how much assistance they need, and we have the other scores if they are not able to do the transfer. And then in this case, or they refuse to do it, we're scoring the discharge goal. So each time we do start of care or resumption of care, we also have to have a second column that says, what do we expect to happen by discharge? And by discharge, what do we think? So we cannot report that the patient does not do it. It wouldn't make sense for a discharge goal. There's no way to use those 3 special codes because that wouldn't be what we would project at discharge. So if the patient is expected to make progress, then we'd expect a higher score than at start of care resumption. If they're expected to decline in progress, we'd expect it lower. And if it's, sometimes if it's just a little bit gradual, maybe they're going to stay the same as they were. So it's based on the clinical judgment of the clinical team. Patient and caregiver can have input. What do you think is going to happen? So here's an example. This patient was very dependent when they came on to services. the wife had to help the patient with everything. There wasn't anything the patient could do independently, so it was maximum assistance. So at start of care, resumption of care, you see at the bottom, O2, substantial maximal assistance. But looking at the patient's prior functional level and his current diagnosis, the expected length of care, his motivation, because he wants to improve, he does want to help get himself out of bed and doesn't want to depend on his wife so much. The clinician expects that by discharge, the patient will be likely to do more for himself. He's still going to require assistance, but not as much. And so based on that, so it's clinician judgment, the discharge goal is determined to be an O3, partial or moderate assistance instead of the maximal assistance that he has at the time of the start of care. And of course, you can measure that based on what happens with it at the end. This question is not completed at discharge, but it will be picked up off of other items that we have. It's only collected at start of care and resumption of care. So moving on. What I want to do here is actually I put these in as kind of an extra for your presentation. Drug regimen review and reconciliation is one of the other very big outcomes that was implemented with the first year of the Impact Act for 2017. It's a very critical area, especially on transition of care, communication, and those kinds of issues. It really involves 3 Oasis items: M2001, the drug regimen review; M2003, medication follow-up at start of care, resumption of care; and M2005, which is medication intervention and follow-up all through the whole episode of care. So it's at any time from, during, or since the most recent start of care, resumption of care. So the next slides 53 through 58, really just go through some of the steps for this. This is not a particular one that is related to skin integrity. Here's just a reminder about the drug regimen review process. If we look at slide 55, we see that we've got some guidance that relates to the drug regimen review, that it does include medication reconciliation, or what is a potential clinical significant medication issue, which is based again on clinician or caregiver's discretion and decision. We also see on the next slide, number 56, it is actually talking about an example of a patient for follow-up from the start of care. So in this case, the nurse completed the drug review. She identified 2 different antihypertensive medications. She contacted the physician on the day of her assessment. The physician wasn't there. She left a message for the physician, went back the next day because she hadn't heard from the physician yet. And this time when she called the office, the physician's nurse in the office was there and said, oh yes, the physician would like the patient to continue with only the newly prescribed antihypertensive medicine and discontinue the previous medication. So how would you respond to M2001? Was there a review done? Yes, there was. And it did show an issue. The nurse did report it. She reported it within the time frame, which was by midnight the next calendar day. And also the physician responded by midnight the next calendar day. It took the nurse 2 calls, but they did get a response. So all of that would mean I could have a response 1 or yes in 201. And then the 2003, did the nurse contact the physician and resolve the issue by midnight the next calendar day? And yes, they did. So these issues very much go together, and we have to actually look at both of them. And just a reminder here that both M203, which is the follow-up at start of care, resumption of care, 2005 is the follow-up for all the time the patient's under care. In physician contact means that there has to be 2-way communication, not just leaving a message, but we actually talk to the physician and the physician actually gets a message back. And it can be physician designee as well. But we have to get the message out and get a response back. Plus, we have to complete the prescribed recommended action no later than 12 midnight of the next calendar day. In our example that we just looked at, The fact was, what we did was we gave the patient instruction about not taking that second medication. So the follow-up was there. So in summary, and I know this is a lot of material to cover in our time. In summary, every member of the home health team needs to be involved in identifying and tracking data leading to these new impact outcomes. Nurses, therapists, they need to be responsible for accurate and thorough scoring on their comprehensive and discipline-specific assessments. If they're doing the Oasis, they need to be accurate as they complete that. All visiting staff members providing care to patients need to document any changes, positive or negative. They need to document any occurrences of skin changes in particular. When did each ulcer or wound or skin lesion occur? When did it start to heal? How did it change? That involves the clinicians. It also involves aides. Aides are often the first to see skin changes. They need to notice there's a change and report it to the nurse or to the therapist that is overseeing that patient's care, or to their clinical supervisor. So everybody has to be involved. The earlier skin changes are noted and reported to the physician, the earlier treatment can begin, the best of prevention can be done if we've got just a reddened area versus a whole breakdown, and the better the odds are that complications can be avoided. So agencies are challenged to develop standardized methods for documenting the presence and changes in individual pressure ulcers, and for describing that. And as an aside, that's the skin integrity one, particularly on the medication one, for documenting what they did about anything, anytime through the episode of care, when they found a problem, communicated that problem, what the answer was back, and what they implemented. Because if it's me that's doing the discharge or you, we have to go back as far as the most recent, at the time of or since the most recent resumption of care or start of care. And if everybody's not documenting and including it, it's going to be very hard for us to get that information. So that actually concludes our particular presentation piece, but I believe, if possible, we may have some time for some Q&As. Perhaps Sarah.
Great. Thank you so much, Judy, for your presentation. This was a lot of terrific, detailed information. I understand that we only have a little bit of time left for questions, but we will be posting a link to this recording on our community site within the next 48 hours. Just go to shieldhealthcare.com/community, and you will find the recording, a link to the recording posted there. To download a printable PDF of the slides, please refresh your screen and then click on the green resources icon at the bottom of the screen. If you found this information useful, we encourage you to sign up for our monthly newsletter, where we share information that's relevant to both healthcare professionals and for patients. You can also follow Shield Healthcare on our social media sites, where we share that information as well. Our healthcare professionals online community is also updated regularly with information about the ongoing changes in healthcare. You can find that community by going to shieldhealthcare.com/healthcare news, all one word, and that's also where you can sign up for our e-newsletter. A big thank you to Judy for presenting today. If you have any questions, please type them in the Q&A box on the left side of your screen. Let me see if I can squeeze in a couple of quick questions. Judy, here's one for you. What suggestions do you have for patients who go home with no pressure ulcers to prevent developing an ulcer and to maintain skin integrity?
I think that's an excellent question, and I think certainly the steps of looking at all the best practices that relate to implementing preventative measures for pressure ulcers certainly starts out with a great assessment to see what kind of risk factors do we have and how at risk the patient might be, but then making sure that everybody understands, the patient, the caregiver, that patient does need to move. They need to change position on a very regular basis. Sometimes we don't think about that with people that are sitting up in a chair, but they're as much risk as sometimes patients in bed if they're sitting in exactly the same position. One of the biggest problems are the recliner chairs, where people are sitting way back and they're maybe pressing on the coccyx. So I think looking at good skin assessment periodically by everybody who's going in, certainly the change in position, implementing any preventative measures that are possible, treating anything as soon as it starts, all very important.
Great, thank you. Another question, what do you report if you have a mucosal injury?
Could you repeat that again? I didn't quite catch it.
Sorry about that. I know there's a little bit of a pause as we transfer back and forth between your camera and ours over here. The question is, what do you report if you have a mucosal injury?
That's another great question. In all of the Oasis directions, Oasis does not capture mucosal pressure ulcers. Certainly WOCN recognizes them, as does National Pressure Ulcer Advisory Panel, but the Oasis document does not. So they are not listed as pressure ulcers in that respect on the Oasis. However, they should be marked as, it should be documented well, location, where they are, how deep they look at, how deep they are at the time when you first evaluate them, and also that should be documented in the record. And I would say, since they cannot be listed as pressure ulcers in the pressure ulcer questions, the M1300 series of pressure ulcer questions, there is a question at M1350 for home health agencies that says, is there another skin lesion or other wound that requires attention? And by all means, it's just a yes or no question, but it's important to recognize that there is this other mucosal pressure ulcer or injury, and you are going to be monitoring it and certainly providing any active treatment that is required for that patient. So I would suggest documenting it there as well. Hope that helps.
Great, thank you so much. It's very helpful, Judy. I apologize, there are so many great questions coming in. We only had time to squeeze in one more, but we will be reaching out to you individually to answer your questions and comments. So please feel free to post them here. This question was about assessing a patient who has a pressure ulcer injury versus a neuropathic ulcer. The question is, how can a nurse assess a patient who has the ulcer or injury versus a neuropathic ulcer? Is there a difference in that assessment?
Okay, if I understood that, the pressure, there is a person who had an ulcer that it might be a neuropathic ulcer or a pressure ulcer, and the differences in assessing it and treating it. Certainly everything in home health requires to have physician's orders in terms of diagnosing, and well, not orders for diagnosis, but the physician must confirm the cause of each ulcer or wound that a patient has. So, but I think our clinicians are very important in that phase because they can provide information. The Wound Ostomy Incontinence Nurses Society has had a wonderful tool. WOCN has a wonderful tool that differentiates ulcers by characteristics between basically between arterial, neuropathic, and venous ulcers. And I think that that's a good tool to be able to look at some of the data so you can document the characteristics of the wound, present that to the physician as part of a query for a diagnosis related to the patient, and then in terms of the treatment, to work together. I've seen many agencies where the nurses take a very, very strong role in collaboratively determining the treatment that works best for healing ulcers or for healing wounds that a patient has. I think most physicians appreciate that information and suggestions. Obviously, it has to be collaborative because only the physician can actually order. So that's kind of a quick answer to that, but I hope that helps.
Great, great. Thank you so much, Judy. This was a wonderful, very detailed presentation, a lot of information here. If you found this information useful and would like to sign up for our next webinar, please visit shieldhealthcare.com/webinars. We have our next 5 or 6 months of webinars listed there, and Judy will be presenting for us again. We're looking forward to it. So thank you again, Judy, for your time today. Thank you, everyone, and have a great rest of your day.